So with that, I'm going to introduce our first presentation of the afternoon. The title is Emerging Treatment and Evolving Pathways for the Management of Chronic Lymphocytic Leukemia, and that's presented by Dr. Jennifer Brown.
Thanks. Hello, everyone. Glad to be here, speak to you today. If I could please have my slides, or maybe I just need to advance them. Here we go. I've served as a consultant for most of the companies that make any of the drugs we're discussing. Our objectives are to understand biomarkers and therapy of CLL in the context of age and comorbidities. So I'm going to start by talking about the current state of prognostic assessment and biomarkers in CLL, and then we'll talk about first-line therapy options and selection of therapy, followed by relapsed refractory therapy. So just to remind everyone, chronic lymphocytic leukemia is the most common adult leukemia with about 17,000 new cases per year. The word leukemia is in quotes because the disease is really more a lymphoma biologically and is best thought of as a chronic incurable low-grade lymphoma, with most patients presenting with an asymptomatic increase in their lymphocyte count and not requiring therapy initially. And in fact, randomized trials have demonstrated that early therapy confers increased toxicity without any effect on survival. Therapy is required once symptoms, cytopenias, or lymphadenopathy intervene. And the criteria for that have been codified in the so-called IWCLL criteria, whereby therapy is initiated for patients with significant symptoms, progressive cytopenias, or massive adenopathy. The latter two of those are really the most common indications. We don't usually initiate therapy just because the lymphocyte doubling time is short, as this can vary significantly over time. Typically, we can manage autoimmune cytopenias without needing to initiate therapy, but if refractory, then we'll start therapy. And note that the absolute level of the lymphocyte count is not a criterion for initiating therapy. I have many people walking around with white counts in the hundreds of thousands who are fine. So how do we decide what is high-risk CLL? And this was historically defined by clinical features at presentation, such as the stage of the disease, the lymphocyte doubling time, and tumor markers like the beta-2 microglobulin, and then after therapy by what happened, namely were the patients resistant to therapy or not. But now we increasingly understand the biology of the disease, and it turns out that biologic prognostic factors are actually much more powerful in many cases. And this includes chromosome abnormalities defined by FISH, mutation of the P53 gene, and IGVH primarily, although we're starting to understand more about the role of novel somatic mutations, but those do not yet influence therapeutic decision-making. So just to review, in a classic paper in 2000, Donor published in the New England Journal of Medicine the frequency of common clonal aberrations in CLL, with 13q deletion being found in a little over half the patients, but not having major prognostic significance. The ones, as we'll see in a minute, with more significant prognostic impact are 11q deletion in about 20% of the patients, and 17p deletion affecting the P53 gene in about 7%. And this is the overall survival curve based on these chromosome abnormalities. You can see the 17p patients had a survival on the order of only 2.5 years. And this has actually only very recently changed markedly. And the 11q patients, an overall survival on the order of 6 to 7 years. The other chromosome abnormalities significantly better. And then the other major prognostic factor is this so-called IGHV status. And this refers to the degree of somatic hypermutation present in the variable region gene of the antibody gene in the CLL cells. And you should just focus on these curves for a minute, because this is actually very old data, patients treated in the 80s and 90s. And you'll note that people with the so-called mutated IGVH, with more somatic hypermutation, even then, when therapy was very limited, had a median survival that was not yet reached at 25 years. So these are patients we need to try to do no harm to, and because they're likely to do quite well. In contrast, the unmutated patients have a steadily declining survival curve and a median survival about 9 years. And this remains a very, very significant prognostic factor to the present time, although there's some question whether it may be changing with novel agents. But the follow-up is still too short to know. And so if we put together our chromosome abnormalities and our IGVH, we see that 17p is the worst in terms of survival, followed by 11q, which is widely variable and in many cases worse than unmutated IGVH without 11q, but in some cases about the same. And then the mutated IGVH are the patients out there on the right doing very well. Now, as you might expect, the 17p and 11q patients are overwhelmingly often unmutated on their IGVH, about 90% of the time. But if they happen to be mutated, then they have a much more indolent course. In recent years, because of the prognostic significance of deletion of 17p affecting p53, people started looking for mutations in the other p53 gene on the other chromosome. And it turns out that the presence of those somatic mutations is also very predictive of outcome, even in the absence of 17p deletion as shown here. Although more recent data suggests that there's a dose-dependent effect, that one copy loss is worse than having both genes intact, and 2 copy loss is worse still, as shown here. And so the most recent effort to put all the prognostic factors together for patients treated in the era of modern chemoimmunotherapy resulted in this CLIPI index, or CLL-IPI, which admittedly was done on patients treated primarily with chemoimmunotherapy, Frontline, but then in later line might have had novel agents. And so this really actually, I think, represents what the sum total of the data would suggest would have fallen out of this analysis, namely that 17p deletion is by far the worst with a weighting of 4, followed by IGVH status with a weighting of 2. And then the tumor marker beta-2 microglobulin is also significant, followed by clinical stage and age, which of course remains significant, as many patients will die of causes other than CLL, especially as they're older. And so if we add up the scores, in order to be in the very high-risk group, you have to have deletion of 17p. And you can see that group has a very poor 5-year survival historically. The high and intermediate groups are somewhat in the middle, whereas the low group is doing very well at 5 years. And that's illustrated here. And so this is an easy-to-remember prognostic index, which is fairly easily incorporated into clinic. So at this point, high-risk CLL comes down to patient factors related to age and comorbidities, oftentimes our ability to give them treatment if they need it, as well as these key biologic factors, 17p, IGVH unmutated, which is what stands for, 11q, and beta-2 microglobulin. The recurrent somatic mutations are, as I mentioned, not yet affecting our treatment decision. This is an interesting analysis that was done in Europe of a couple thousand early-stage patients in which they found that essentially the presence of any of the common recurrent somatic mutations was associated with a much shorter time to treatment than patients without those mutations, as shown in the left panel. And if we incorporate IGHV status, we get an even more favorable curve on the right for the patients with the favorable mutated IGVH and 13q deletion, whereas everyone else is moving relatively rapidly to treatment. Okay, so what about treatment? So this summarizes the history of frontline treatment for CLL, starting with single oral alkylating agents, moving to purine nucleosides, adding alkylators, and of course currently we're in the era of chemoimmunotherapy, adding rituximab initially to chemotherapy, which was the first overall survival benefit seen early in CLL. And now in the 2010s, the era of novel agents. And so the first pivotal study in this era was CLL-8 from the German CLL Study group, which randomized 817 patients with good physical fitness. And it's important to focus on the eligibility and what patients were enrolled in all the trials. So these patients had low comorbidity scores less than 6 and excellent creatinine clearance of above 70. Most of them were relatively young, median age in the early 60s, but about a quarter to a third ranged up into the 70s as long as they met the fitness criteria. They were randomized to receive FCR versus FC. The progression-free survival approach is 5 years for FCR versus a little under 3 for FC. And there was a 6% overall survival benefit that was seen first at 3 years and maintained subsequently. However, our 17p deletion patients still were not doing well, as shown here. Their median overall survival still only a couple of years. And this was also true of those with mutation of the p53 gene, shown here. And in the overall multivariable analysis, receiving FCR was predictive of better progression-free and overall survival, while having mutated p53 was predictive of worse progression-free and overall survival. The other mutations that are common in CLL, SF3B1 and Notch1, were associated with progression-free but not overall survival. The MD Anderson has longer-term follow-up data, and in their data, again, we see how poorly 17p does in yellow, with 11q starting to drop off also in green. Now, in follow-up, as bendamustine rituximab became very common, the German CLL study group did CLL10, comparing FCR versus BR, in a very similar patient population to CLL8, again, patients with good renal function and low comorbidity. But in this study, they excluded the 17p patients who did so poorly on CLL8. And this study is still relatively short follow-up at 3 years. The progression-free survival was significantly better for FCR than BR, although BR was better than FC. The complete remission rate was better for FCR than BR. The bone marrow at final restaging, in terms of the presence of minimal residual disease, was much improved with FCR compared to BR. And this is generally true, that we see higher rates of MRD negativity with FCR than with most other regimens. However, the toxicity of FCR was higher, as shown here. There was more neutropenia and more infection. Now, in part, this is because the study didn't mandate growth factor prophylaxis or infection prophylaxis, which is generally our usual practice with FCR. However, the data are as they are, and this is what was observed. Treatment-related mortality, however, was not significantly different. Then the other important aspect of this toxicity was that it was concentrated in patients over 65, even though they met the fitness criteria. As shown here, about half the patients receiving FCR over 65 had significant infections versus about a fifth of those getting BR. The other point is that delayed neutropenia is more common after FCR, and so infections were more common in that period immediately after therapy. Now, the predictors of progression-free survival in this study, interestingly, where 17p was excluded, included treatment arm again, but also IGHV status and 11q status, which I think underscores that after we take out the 17p and p53 as the highest risk group, then our next risk groups are unmutated IGVH and 11q. Overall survival was predicted by age and IGHV status. So again, patient factors and the key biologic factor when you've excluded 17p. So in summary of this study, FCR is more effective in inducing complete remissions and MRD negativity, and I'll show you in a minute the importance of MRD negativity, as well as for progression-free survival. But this effect is particularly noticeable in younger patients under 65. The toxicity is higher, especially in those over 65, and certainly growth factors and antibiotic prophylaxis are important in this population. And so FCR is definitely the standard for young fit patients. For those who are older and fitter of intermediate fitness, there's still a role for bendamustine and Rituxan to minimize toxicity. But in considering this choice, it's important to remember the long-term follow-up data that we've recently seen with FCR from the MD Anderson, from the German CLL Study group, and also from the Italian group. And these are the data from the MD Anderson, which demonstrate that out 10 to 12 years after therapy, there's a plateau on the progression-free survival curve after FCR at about 35 to 40%. And most of those patients are those with the favorable mutated IGVH, who actually have a 55 to 60% chance of remaining progression-free at 12 years after therapy with FCR. Whereas the unmutated patients, as you can see, show continuous relapse and about a 10 to 15% long-term plateau. Remaining on that plateau is highly correlated with achieving MRD negativity at the end of therapy, these being data from the MD Anderson looking at a more recent cohort where you can see that MRD negativity was associated with an excellent progression-free and overall survival compared to those who were positive. And here, this is broken out by IGHV status, where the blue patients are those who are mutated IGVH and MRD negative. The red patients are actually unmutated MRD negative, and so they can have quite prolonged remissions too. But of course, prior to therapy, we can't tell which of them will be MRD negative versus not, unfortunately. We don't have predictors of that. And these are the Italian data showing that for patients without the high-risk chromosome abnormalities of 11 or 17 and with the favorable mutated IGVH, if they don't relapse in the first 3 to 4 years after therapy, they have a survival comparable to an age and sex matched population in the blue curve on the right. And in fact, the low-risk group has the lowest incidence of second malignancy in the Italian data, probably, again, because their disease is so well controlled. And we know that a lot of the second malignancy risk in CLL is actually from the disease, probably, rather than the treatment. In the MD Anderson data, you can see that by far the greatest risk group over time are the unmutated IGVH patients from their CLL, rather than from other cancers or Richter's transformation. Now, the UK group has recently published some data looking at over 1,000 patients in terms of MRD negativity, which is illustrated here, showing the significant predictive benefit of achieving MRD negativity after any therapy in any line of therapy for progression-free and overall survival. The only group it doesn't seem to help, unfortunately, are the patients with 17p and 11q deletion, who still show continuous relapse. And achieving this MRD negativity is better after frontline therapy. And so as we move into the era of novel agents, I think it's important to remember that achieving MRD negativity is associated with very good long-term survival outcomes, and that we may want to move toward being able to do that with novel agents. So in summary of fit patients, FCR remains the most effective upfront therapy. Subset of patients remain progression-free more than 10 years later with mutated IGVH and low-risk FISH. And the key predictors of outcome are 17p or p53 mutation, 11q deletion, IGHV, and then response and MRD status. So what about unfit patients? It was shown very early on that they do not benefit from fludarabine compared to chlorambucil. And as a result, chlorambucil has remained the basis of most randomized trials since then. And some of that is likely because of the increasing rate of comorbidities associated with increasing age and therefore increasing complications from fludarabine. And so CLL11 defined the standard therapy in this population prior to novel agents. And these patients have comorbidity scores greater than 6 and/or reduced renal function. And the trial randomized patients between chlorambucil alone, obinutuzumab chlorambucil, and rituximab chlorambucil, and compared each antibody arm to chlorambucil and the two antibody arms to each other. You can see that this antibody clears blood very effectively of disease. Baseline patient characteristics, again, demonstrate that the patients were in their early to mid-70s with significant comorbidity scores of 8. Toxicity is actually quite minimal with this regimen. There's a somewhat higher rate of infusion-related reactions on the first infusion, but then after that, it was fine. And neutropenia was about the same with the two antibodies. Minimal residual disease clearance is better with obinutuzumab. Progression-free survival is better with obinutuzumab than rituximab, shown here. Overall survival was improved with obinutuzumab chlorambucil compared to chlorambucil alone, but not compared to rituximab chlorambucil. But I think the most interesting piece of data from this study is actually this long-term follow-up shown here, which is that it was over 4 years median time to next treatment for the patients who received 6 months of this very easy, gentle therapy without much toxicity. So unfit patients, randomized phase 3 trials established the progression-free survival benefit of adding any anti-CD20 antibody to chlorambucil, but only obinutuzumab was compared head-to-head with rituximab, improving MRD negativity and PFS, but not OS. And the time to next therapy is quite good for 6 months of a well-tolerated treatment. However, this is also the patient population in which we have randomized data I'll show you for ibrutinib, and kinase inhibitors are likely moving into this space where resources permit. And so we'll talk about ways in which therapy might be selected. But first, the ibrutinib data. So these are the longest follow-up data that we have with ibrutinib from the original phase 1b/2 study, 31 treatment-naive and 101 relapse-refractory patients, now reported at 5 years. At that point, 65% of the treatment-naive patients remained on drug and about 30% of the relapse-refractory. And the median PFS in the relapse-refractory population had been reached at about 4.5 years. Chromosome abnormalities are still quite predictive of outcome, with 17p having a median PFS of 26 months and 11q a median PFS of 55 months, whereas the lower risk abnormalities are still doing very well on the left. Now, it's important to point out that even though the 17p curve looks much worse than the other curves, and is worse, it's still the best survival curve that we've had with any therapy in this patient population. And therefore, ibrutinib has moved rapidly into the early therapy of that subgroup of patients. Now, another predictor of outcome was the presence or absence of complex karyotype, meaning at least 3 abnormalities on stimulated karyotype. This is not a widely available test, unfortunately, and we don't tend to get complex karyotype data reliably for normal unstimulated karyotypes. And as we move into the ibrutinib era, this is likely to be a test that we're going to need more frequently. Now, complex karyotype does correlate with 17p deletion. There's been some debate which is more important or whether both are important. And so this is an analysis of 240 patients with 17p deletion in terms of their progression-free survival on ibrutinib. You can see that about 55% of them were progression-free at 30 months, fairly similar to the 1102 data. But this was strongly predicted by the presence or absence of a complex karyotype. Those with complex karyotype had only about a 2-year progression-free survival versus 4 for those without. Over half of 17p patients in relapse do have a complex karyotype, though they're pretty correlated. Now, what about RESONATE, the relapsed registration trial for ibrutinib, in which it was compared head-to-head with ofatumumab? The follow-up of this curve is about 2 years, but is very similar to the recently reported 4-year data, where you can see that the ibrutinib-treated 17p patients appear to be trending a bit lower, but this is not statistically significant compared to those without 17p. However, if you actually analyze it with respect to whether or not the other p53 gene is mutated, which it is in about 80% of relapsed 17p patients, you see that those patients with mutation of both alleles, having a double hit of p53, do have a statistically significantly worse progression-free survival curve. But again, the best curve that we have, possibly barring venetoclax, which looks fairly similar in this patient population. And so, as a result, even though we have very limited data for upfront 17p, ibrutinib has definitely become standard of care. And this is really the only data that we have, 35 previously untreated patients from an NHLBI study with a 2-year follow-up and progression-free survival of about 80%, which is likely better than we would see in general practice or even in other clinical trials, as the patients who are able to make it to the NHLBI study are often quite selected. And so where do we stand with ibrutinib for 17p deleted CLL? As I've mentioned, it's clearly the drug of choice, Frontline. But I find it unsatisfying as a single agent because we still see transformation early, we still see continuous relapse. But we don't yet have any combination data in an upfront setting, although there are a number of trials ongoing, because this is clearly the population in which it would be nice to have novel combination therapy. And it's still a patient population with unmet need in whom we need to consider early evaluation for allotransplant if the patients are young enough to be candidates. So what about the non-17p previously untreated patient population? And so there we have RESONATE-2, which enrolled 269 treatment-naive patients over 65 without 17p deletion and randomized them between ibrutinib and chlorambucil. Ideally, the control arm here would probably have been chlorambucil obinutuzumab, or at least chlorambucil rituximab, but it's single-agent chlorambucil. And the patients are in their early 70s, but they're a somewhat unique population. I draw your attention to the SEERS score then, the comorbidity score, which we discussed has to be less than 6 for patients going on the chemoimmunotherapy studies, but for the CLL11 obinutuzumab chlorambucil study was a median of 8. So in this study, only a third of the patients, despite their age, had a SEERS score above 6. So most of these patients were actually very fit. And their disease was not terribly advanced either, with about 45% advanced stage disease, 40% bulky. There were, however, 20% 11q deleted patients, which represent the highest risk group in the study. And so, as we might expect, ibrutinib handily beat chlorambucil for progression-free and overall survival, with a 24-month progression-free survival now of about 90%. There were some significant adverse events, which are part of what we know about ibrutinib: 14% hypertension over time, 6% atrial fibrillation, which goes up to about 13% at 3 to 4 years, 4% major hemorrhage early on, and 2 sudden deaths. So this curve illustrates that regardless of IGHV status, patients did well on ibrutinib. And this has been a consistent finding in most of the trials, including even the 5-year follow-up 1102 study. However, I think we need longer follow-up of these studies to find out whether, in fact, those curves may diverge. Ibrutinib being a highly potent drug, we may have simply moved the divergence out beyond what our current follow-up is. But this doesn't negate the fact that in early several-year follow-up, the unmutated patients do very well with ibrutinib. Overall response rates are very high. CR rates, as you know, with ibrutinib are low. In the relapse setting, they plateau at about 10%. In the upfront setting here, they are slowly increasing over time, up to about 18% at 2.5 years. But most patients still have some residual disease, suggesting that they need to stay on the drug to maintain their benefit. And the adverse event profile does tend to go down over time, particularly with respect to infection. But there is a continuous rate of major hemorrhage, which is up to 7% at the 2-year follow-up, and atrial fibrillation was at 10% in 2-year follow-up. So I think we need to recognize that the study is not really a representative population of standard clinic patients. They're very healthy, older patients who had relatively low disease burden and disease risk. And our follow-up is still short. And so this is important to keep in mind. And the toxicity profile, which we'll talk more about with ibrutinib, is not negligible. So this is the longest follow-up of a cohort of patients at Ohio State, illustrating why patients come off drug. And in blue, we have so-called other events, which are mostly coming off for toxicity. And so you can see that that occurs particularly early and then plateaus at about 3 to 4 years. The yellow curve is Richter's transformation, which again occurs over the first 1 to 2 years and then plateaus at about 10%. And CLL progression is low early on, but then starts to continuously rise around 2 to 3 years and is up to 20% at 4 years. And the predictors of these events differ. So the predictors of Richter's transformation include complex karyotype as well as MYC abnormalities, which we know are present at a high rate in Richter's compared to CLL, so those make sense, although the biology of Richter's is still being elucidated in both this context and any context. For progressive CLL, the predictors again are complex karyotype, which we saw in the studies that we looked at, and 17p deletion. Both of them were independently predictive. And interestingly, age. Older patients did better, and there was a higher relapse rate in younger patients. And the biologic basis of this and whether it would be reproducible in other data sets is not known. But I do think it urges some caution in the widespread adoption, for example, of the RESONATE-2 data in younger patients. And then the other events, the toxic reasons for coming off, are very age-dependent and also prior therapy-dependent. And that's illustrated here, where you can see that for our typical patients in their 70s, they have about a 30% chance of discontinuing ibrutinib over a year to 2 years. But for those in their 80s, it's up around 70%. And so why does this happen? So Mato et al. Presented an analysis of reasons for discontinuing ibrutinib in more standard clinical practice, mostly non-trial patients. And the most common reasons were atrial fibrillation in 20% of patients, infection in 12%, hematologic toxicity or cytopenias in 9%, bleeding in 9%, and pneumonitis in 8%. Fortunately, if you came off for toxicity, you did much better in terms of your progression-free survival than those who progressed, however, as illustrated in this curve. And they did a follow-up study of over 600 patients, including a subset of frontline patients with high-risk disease, as shown here. And in this follow-up study of more routine clinical practice, about 40% of patients actually discontinued ibrutinib with a median time to discontinuation of 7 months. Again, mostly for toxicity. And the median progression-free survival in that context was about 3 years. Complex karyotype, again, predicted progression-free survival. And so this suggests that we're not seeing in clinical practice the same rate of continuation of ibrutinib and likely as a result not the same progression-free survival that we see with the trials. And some of this may be older data before everyone has gotten more comfortable managing the toxicities of the drug. But it's clearly something that we need to understand better for figuring out what the natural history of the disease and its management will be going forward. So some of the toxicity, just honing in on it. So bleeding events tend to occur earlier, but there is a continuous rate. Ibrutinib inhibits platelet function, but not number generally. And about half of patients will have significant bruising. But there's about a 5% rate of major hemorrhage, and caution is definitely indicated using any anticoagulants together with ibrutinib. And then atrial fibrillation, similarly, is highest in the first 6 months, regardless of whether patients have a prior history or not. But there's a continuous low rate, as you can see in the bottom graph, out at the 3-year follow-up. The risk factors, based on an analysis that we did of 4 randomized trials, included a prior history of atrial fibrillation, receiving ibrutinib, and older age. Neither hypertension nor hyperlipidemia was significant in multivariable analysis. But the great majority of patients with a prior history of AFib or with these risk factors did not get AFib on ibrutinib in the randomized trial analysis. Some of the analysis of patients in routine care has suggested more complications and more difficulty continuing ibrutinib than we saw in the patients on the trials. And so again, greater clarity will be needed on this over time. So ibrutinib in relapsed refractory CLL has excellent results, mostly partial responses. The median progression-free survival is about 4.5 years on clinical trial, but worse for those with 17p, complex karyotype, and 11q. But outside trials, it's been reported that 40% of patients stop at about 14 months with a median PFS of 36 months. And so we're going to need to better understand how real-world outcomes align with trials going forward and perhaps come up with better management strategies for toxicity and or potentially less toxic next-generation BTK inhibitors are in clinical development. The other issue which has arisen is that patients who've progressed on ibrutinib have been fairly difficult to salvage. Those who transform are always difficult to salvage, but even those who progressed with CLL, typically with the BTK mutation in the target cysteine for ibrutinib, have also been difficult to salvage. And the reason for this is not entirely clear as yet. Biologic studies are ongoing. And it's also not clear that it is as difficult in patients who are less heavily pretreated at the time they progress than in the early studies. But again, we have only early data on that. And so in addition to what I've mentioned about RESONATE-2, again, just to highlight that we have no data on ibrutinib for upfront therapy of young, fit patients yet. There are 2 randomized trials ongoing comparing ibrutinib rituximab to FCR, but neither of them have reported out any data yet. And some of the features that conflict with going on continuous single-agent ibrutinib for all of our patients actually include that patients often don't want indefinite therapy initially. They don't achieve complete remission, which is appealing because your disease is gone. Even if it will come back eventually, it's still gone then. We're concerned about ability to salvage on relapse. We don't know we can use chemoimmunotherapy later. There are absolutely no data on that yet. And then there's the question of long-term cost as well as patient compliance, given some of the tolerability over time. Patients have edema, they have easy bruising, arthralgias can be a big problem. Okay. And much has been made of data on response to ibrutinib by line of therapy, and these are the data from the RESONATE registration trial, where patients with 1 prior therapy you can see are doing extremely well and better than those with 2, 3, or 4 prior therapies. However, if we align the 1 prior therapy with those with no prior therapies from RESONATE-2, those 2 curves are actually not statistically different. Now, this may change over time. We don't know. But if it doesn't change, then, again, for patients with lower risk disease, they may not need to receive ibrutinib up front. Second line may be fine. Our follow-up is just not long enough to know. So going back to the curve for progression. So the only drug that we now know works in patients who progress on ibrutinib, in contrast to those who come off for adverse events, is venetoclax, a BCL2 inhibitor. And these are the data from the original phase 1 study. Overall response was 79% and was similar in 17p patients. The CR rate is higher than with single-agent ibrutinib, as this drug actually clears bone marrow more effectively. And the only group in which it does not work as well are those with bulky lymph nodes, shown at the bottom, whose CR rate was lower. The median PFS in this study was 2 years. It was 16 months in those with 17p deletion. Adverse events include diarrhea and generally manageable neutropenia. The major side effect of venetoclax that causes problems is really the tumor lysis syndrome early on, which led to deaths in the clinical trials. The label includes a detailed risk stratification that was developed from modeling of the trials, which assigned patients to low, medium, or high risk based on their nodal mass and their white count, and then assign a degree of monitoring for tumor lysis over the slow dose escalation based on that. And since this has been implemented, the tumor lysis has generally been pretty manageable. The dosing schedule is shown here with the ramp up 20, 50, 100, 200, 400, with each escalation requiring monitoring for tumor lysis and potentially done in the hospital for patients with high-risk disease. Now, venetoclax has been studied in a phase 2 study in patients with a median of 2 prior regimens with 17p deletion. These were very high-risk patients. Response rate was 74%, and there was actually a rate of MRD negativity, which is quite striking, even though it's not high, it's a low percentage. But nonetheless, the fact that it was achieved in any of this patient population was striking. Duration of remission is 85% for all responders and 100% for those in complete remission at 1 year. Progression-free survival of 72% at 12 months. Now, I should say that ibrutinib a very similar study was done with ibrutinib, a phase 2 study in 17p deleted patients, and the data looked very similar. But ibrutinib has really been moved frontline for 17p, as the venetoclax label is limited to relapse. A pooled analysis of all the data on venetoclax efficacy show a 75% 1-year PFS and about a 58% 2-year PFS, again, with about 15% MRD negativity in very relapsed refractory patients. The MRD negativity and complete remission are very predictive of prolonged durability of response, as shown here. More than 90% of patients were still in remission at 2 years if they were in complete remission or negative for MRD, which is really very striking and provides us with perhaps some ability to predict who will do well longer term on venetoclax versus who is likely to relapse. The other advantage of the MRD negativity with venetoclax is that it offers the opportunity to potentially do time-limited therapy for patients who achieve MRD negativity and hope that they will remain in remission. Now, these are the data for venetoclax after failure of ibrutinib, which is, I mentioned, this is the only systematic study in this patient population. And arm A are the patients post-ibrutinib. They're very high risk. Half have 17p deletion, median of 4 prior therapies, and they generally were all refractory to ibrutinib, came right off ibrutinib, and went on venetoclax. Toxicity was similar to those who had not been previously exposed to ibrutinib, and response rate of about 70%. But you'll note that the complete remission rate was lower, which does raise the question of whether the durability will be similar in this patient population to what we saw in those who were not exposed to ibrutinib. At present, we don't know that because the median follow-up is only about 11 months. At 12-month estimated, the progression-free survival is 80%. However, many of the patients in the other study who achieved only partial remission tended to relapse in year 2 and year 3, and so we're still awaiting that follow-up of this data. So in summary, venetoclax, as a single agent, has an overall response of 76%, complete response of 22%, and 15% bone marrow MRD negativity. And these latter features predict durability of response. Activity is preserved in 17p patients and those who progressed on ibrutinib or idelalisib. Have to be very careful due to tumor lysis. We don't have data yet in the upfront setting. And resistance is likely to emerge, and there is an early signal that perhaps there's an excess of Richter's transformation in those relapsing on venetoclax. This has also been seen to some extent with the ibrutinib studies, and it remains highly controversial whether this is related to the drugs or just that we're keeping patients alive longer to undergo the natural history of their disease, which would have been to transform. And we don't know the answer to that yet. All right, a brief word about Pi3 kinase inhibitors. So idelalisib is a very, very active drug in both relapsed refractory and untreated CLL, but causes a wide range of toxicity that is limited to its use. And I like to group the categories of toxicity into several categories. So one is an autoimmune toxicity related to CD8 T cell infiltration in the liver, which causes transaminitis, and the colon, which causes an inflammatory colitis, and the lung, which causes pneumonitis. And this generally needs to be treated with rapidly holding the drug and giving steroids. There's neutropenia and sepsis, which was the primary cause of the infectious deaths that led to the halting of the upfront trials a year and a half ago. This is particularly bad in combination with chemotherapy, but can happen with single agent. And then there are opportunistic infections, pneumocystis and CMV, which may be related to impact on T cell function. And so given that we are not yet able to predict who's subject to these toxicities, and they can be quite severe and come on suddenly, idelalisib use has been limited to the relapse refractory setting where the risk is lower than in earlier treatment settings, and generally after ibrutinib. We don't have data on response in those who progress on ibrutinib, so those who come off for adverse events, for example, are reasonable candidates. There are several other Pi3 kinase inhibitors in registration trials. Duvelisib seems to have a similar toxicity profile. The TGR-1202 drug seems to be better tolerated, but we know very little about how it's actually working in vivo. We don't have any pharmacodynamic data that it is, in fact, inhibiting Pi3 kinase. It also inhibits casein kinase epsilon. And so we still have much to learn about these drugs. So where are we? We have highly effective risk stratification for CLL. We have highly effective chemoimmunotherapy. We have 3 classes of highly effective oral targeted inhibitors that are mostly approved to be given as single agents continuously. But we still have very limited data on whether sequential therapy will work for most patients, and in what order, including whether chemoimmunotherapy will work after novel agent therapy up front. We also have very limited data on combinations or time-limited therapy, or outcomes after discontinuation for progression or adverse events, particularly for patients who receive ibrutinib frontline or second line, what their outcomes are after discontinuation. And follow-up is short. Relapse therapy for CLL is perhaps more straightforward than frontline therapy right now. If patients have not received ibrutinib, we tend to use ibrutinib. Now, this may change as we're expecting an expanded venetoclax label for most relapse patients. But those who have very long response to prior chemoimmunotherapy and no adverse prognostic markers, you can possibly consider repeat chemoimmunotherapy, although we tend not to do it. For those who've progressed on ibrutinib, then venetoclax is really the only drug with good data. And if you're off ibrutinib for an adverse event, then idelalisib or venetoclax. This is a chart that I recently published for selection of frontline therapy for CLL. Again, patients who are asymptomatic are not treated, even 17p patients, even now. They're observed until they have symptomatic active disease. Those with 17p go to a clinical trial, ibrutinib, venetoclax. Those without 17p, again, the fit younger patients with mutated IGVH, we really favor FCR based on the long-term data. Those with unmutated IGHV in that group, I still tend to favor FCR, given that we do have long-term data and we know ibrutinib works very well after FCR. We don't have a timeline beyond several years with ibrutinib frontline, but we're awaiting randomized trials that will inform that decision. For the older fit patients, move to BR or perhaps PCR versus ibrutinib. The less fit patients, we have obinutuzumab chlorambucil or ibrutinib. Although again, as I mentioned, we don't really have ibrutinib data in this patient population, which is why for the unfit patients, we tended to favor the antibody chlorambucil combinations over ibrutinib. So should these biologic agents replace chemo? Well, the pros are they're oral, they're well tolerated, they're highly effective even in high-risk disease, although this efficacy difference is most marked in the relapse setting, except for the very highest risk disease. As I mentioned, we have ongoing randomized trials. The cons are they're given continuously indefinitely. Many patients, in my experience, don't want that. They want to do 6 months and be done for potentially 5 or 7 or 10 years. We don't want to abandon what may be cure with FCR in the IGHV mutated CLL patients. But again, that young fit population is a limited percentage of our patients. There's the problem of the low-grade nagging side effects, which may lead to compliance issues, as well as unknown long-term effects. Tolerability worsens with increasing age. We have unknown ability to salvage. And then there's the cost problem. A recent cost analysis for CLL therapy was published in JCO, and this illustrates the assumptions that were made in terms of the targeted therapy scenario versus chemoimmunotherapy scenario. So from 2011 to 2014, we had chemoimmunotherapy. 2014 to 2016, we had novel agents for relapse. And then since 2016, they modeled oral ibrutinib frontline, followed by either chemoimmunotherapy or other novel agents after. And then chemoimmunotherapy is the comparison scenario. And so with this model, they estimated an increase in lifetime costs to payers and patients of about 6-fold, 6 to 7-fold for each group. And this illustrates how that may continue to go up over time as the patient population expands and more patients are on drug. Now, this does assume that patients will remain on the novel agent indefinitely, which, as I showed you, may not be true. Patients tend to fall off for adverse events after 2 or 3 or 4 years. So how can we reconcile these issues? And I think that there are 2 main ways that we may be able to address achieving the maximum benefit for patients as well as patient-friendly therapy, while at the same time perhaps not skyrocketing costs as much as that suggests. So one is risk-adapted frontline therapy. I showed you the curve for the mutated IGHV patients from the 80s. These patients do very well with very little therapy, often for very long times. And so if we follow that risk stratification and manage patients in accordance with their expected disease behavior, assuming that is what we observe, then those patients can receive relatively minimal therapy versus the high-risk patients need novel agents up front. And then the other option is to find effective, well-tolerated combinations that we give for a time duration of 6 to 24 months, induce deep remissions, and then stop. Patients would like that. It reduces side effects, it reduces costs, and then there's also the possibility that when they relapse at a long time later, they won't actually be resistant, and we could give the same regimen again. But unfortunately, as yet, we have very little data demonstrating that any of that is true, and we just have trials initiating that plan to discontinue the drugs fairly recently. So my view of the future is that fit or higher risk patients will get combination therapy to achieve deep, ideally MRD negative remissions, perhaps cure, and then get treatment breaks. Save money, toxicity, avoid resistance. The sequential single agent model has many complications, but it may be adequate for the older, more frail patients with higher risk disease, or for those with lower disease risk who may even be able to get 6 months and then stop for years, even if they still have detectable disease. And so high-risk 17p patients will probably get novel multi-agent combinations. Older, higher disease risk patients, like those with 11q or perhaps IGHV unmutated, will get inhibitors or a combination. Those with low disease risk can probably continue to get antibodies, plus minus chlorambucil. The young IGHV mutated patients, FCR-based therapy. And the younger IGHV unmutated patients is really where we need more data, because they continuously relapse with FCR, but we have no data with ibrutinib yet, and it would be nice to have a regimen for them that will induce MRD negativity and allow stopping therapy. So ongoing clinical trials, I mentioned the ibrutinib, Rituxan versus FCR trials, and then venetoclax, the German CLL study group, has ongoing trials, venetoclax obinutuzumab versus chlorambucil obinutuzumab, and then for the younger patients on the left, a 3-drug regimen, ibrutinib, venetoclax obinutuzumab versus venetoclax obinutuzumab versus venetoclax rituximab versus chemoimmunotherapy. And so those will be very informative, but it will be a number of years till we get data from them. All right. So thank you for your attention.
Thank you, Dr. Brown. We do have about 5 minutes for questions, so please, you're welcome to use the center microphone. Welcome comments as well. Whether you have comments or questions, just we ask that you be mindful of the other audience members and try to be succinct and not monopolize the mic. So please go right ahead.
Hi. So how do you incorporate this into pathways?
So 17p clearly has its own pathway, which is ibrutinib, venetoclax, and consider allotransplant. The young fit patients, I would favor FCR, because particularly if you're not measuring IGHV, you need to offer FCR for the mutated group, frontline. Then the older comorbid patients, it's really, ibrutinib is a reasonable choice, and so is obinutuzumab chlorambucil, so is BR. I tend to make that decision based on the risk stratification of IGHV and FISH. So I would argue that we should move toward pathways that actually stratify both the young fit and the older patients based on IGHV and FISH. But that is obviously not where we are yet.
So where is value in that?
Where's the value?
Well,
cost. That's going to result in a large subgroup of low-risk patients who don't need to go on ibrutinib for life with toxicity and cost and compliance issues, who get 6 months and then are good for 4, 5, 6 years.
But can you actually quote numbers for cost and quality being outcome versus over cost, which is
so there's very little data. Our longest term follow-up with our longest term follow-up is 5 years in 100 relapsed patients. In the upfront patients, we have 200 patients followed for 2 years. We have almost no data. It's just very early days. And there are, I think, 3 cost analyses and 1 quality analysis. It's just very, very early. And like I said, we don't even know if patients in the community are staying on the drugs. We need to know what's going on in the community and have longer-term follow-up, and then we can start to
I'm trying to be
understand
provocative here because it's a wonderful comprehensive lecture, but we are in a Clinical Pathways Congress in which we are supposed to have hard defined pathways designed by the best of knowledge at the very moment, and if you will not follow, you're off pathway. So, you are the best person to design and propose those pathways, and even if we don't have long follow-up and costs, so be it. You have to have a pathway.
Right, so in NCCN as well as at our own institution, we've left, except for 17p patients, we've left chemoimmunotherapy, FCR for younger patients, BR or chlorambucil as the frontline therapy of choice in the absence of a contraindication, and then ibrutinib second. That's how, we can't recommend ibrutinib for young fit patients in whom it's never been studied. So.
Thank you very much, Dr. Brown.